We're going to walk you through an overview of the report and the indicators. I'll walk through an example, discuss some of the change ideas and other resources available to you, and then followed by a discussion. We will be having some polls throughout our session today so that we can find out what you would like to get most out of this webinar, as well as for additional supports or things that you would find helpful to support you in your practice moving forward. With that said, we're going to begin our first poll. And the first question to you is, best meet your needs, what would you want to get out of today's webinar? And you can select all that apply. The answers are, what are the indicators measuring, how to interpret the data, ideas and suggestions for how to act on the data, tools and resources, and hear what others are doing. I've opened up the poll. If you can please select what you would like to learn about today. Okay, we'll give people just another moment. Okay, we're going to close the poll. So we have 86% wanting to know more about what the indicators are measuring, so that being tied with interpreting the data as well as some suggestions and ideas for that. So that's very helpful in how we can help you in today's discussion and make it more targeted to what you guys are wanting. Now I'm going to hand it over to Dr. Julie Auger, who's going to walk you through an overview of the report.
Thank you very much. All right. Thank you for joining us, everybody, today. I will walk you through the next few slides, going through the report itself. We could have the next slide, please. Thank you very much. So the long-term care practice report is a report that is focusing in its first iteration on the prescribing of antipsychotics, and it will help contextualize some of the information given in that report as well. The indicators that we report on include the overall rate of antipsychotic prescribing, prescribing for new starts of antipsychotics, continuous use of antipsychotics, polypharmacy, which we define as the use of two different antipsychotics concurrently, and we also report on the CHI-HI indicator of the inappropriate antipsychotic use indicator that CHI-HI puts out. The report is confidential to the physician and is provided on a voluntary basis if a physician registers for it. The data for the report is updated quarterly, and over time will allow trending and comparison, and it also will continue to include quality improvement change ideas within the report. Next slide, please. So we have another poll for you. In terms of accessing your report, what is your preferred method to receive your long-term care report? What has been your experience going to get your report? The choices are the current method, which is through a secure portal at HQO, through their website. B is a direct link through email. C would be a combination of A and B, and then D is any other, open to any other suggestions. So if you could go ahead and quickly respond to that, that will help us streamline the process of how to get the reports to you.
So we have most people wanting a direct link through the email. All right.
Thank you for that. We'll bring that back to the group to see if it can be streamlined. Going on to the indicators discussed in the report, there are a number of indicators, and we think it's important that you know that these indicators were chosen after being vetted through a variety of stakeholder groups, most of them through practicing clinicians, some of them through sector partners and organizations that provide long-term care, that function within the long-term care sector. The first one is the overall rate, and it essentially looks at the number of residents with at least one antipsychotic prescription dispensed compared to the total number of residents in your care. The exclusions to this group are 66 years of age or older, as well as receiving end-of-life care or palliative care. We can stratify these by long-term care homes as well as by diagnosis, and the data is updated quarterly. So this table and the next slide includes a similar table. We'll go through all the indicators, identifying, the numerator, denominator, what it excludes, as well as what stratifications are possible, and the data updated. So again, we'll have overall rate, new starts, which is the number of residents with at least one antipsychotic dispensed without any previous dispensing of an antipsychotic in the previous 12 months. And the continuous use indicator is residents with an antipsychotic dispensed for 90 days or longer. And the exclusion for this one would be somebody who has been in long-term care for less than 100 days. We had some debate over what the exclusion period should be, and it varied depending on who we spoke with, between 30 and 100 days, but ultimately we decided to allow a slightly longer exclusion period, as there's an overall feeling that when people are newly admitted to a long-term care facility, there tends to be a monitoring and an observation period that takes place before the new physician responsible for that resident starts to act on the medications and to either justify or determine why they're not justified to continue on these medications. So that's why there's the 100-day exclusion. Next slide, please. As mentioned previously, the antipsychotic polypharmacy talks about the number of residents with 2 or more antipsychotics antipsychotic residents each for 3 continuous months. So again, it's the use of 2 concomitant antipsychotics. And again, the exclusions are similar to previous, 66 years of age or older, end-of-life care, or if they've been in long-term care for less than 100 days. And then the final one is the CHI antipsychotic indicator, and this is the number of residents who received antipsychotic medication according to their target RI-MDS assessment. And again, the exclusion is end-stage disease or hospice care. That data is only available for update yearly at the current time through CHI. Next slide, please. Please feel free to submit your questions in the question box by typing them in at any time during the presentation, and we'll do our best to answer your questions. Next slide, please.
So Julie, I'll just check in to see if we haven't received any questions so far, and we haven't. But feel free at any point, and we will get your questions answered. So I'll move to the next slide. What I'll ask you to do for Julie to walk through an example, because there are no questions at this time.
Thanks, Stacey. If you go to the next slide, the dashboard. So this is what you received once you downloaded your report. This is the dashboard that we've put together, and it gives you a snapshot, a very visual glance at what your data inside your report is going to describe. So it essentially identifies the data sources where your data was collated from, as well as which LIN you belong to. And then you'll have the 4 graphs which indicate your prescribing patterns for antipsychotics. So your overall rate, your new start, continuous use, and antipsychotic polypharmacy. And you'll notice 2 lines in your graph. You'll have the green one, which is your own residence, and then the other line is the Ontario data superimposed to see where you fit in compared to your provincial comparators. And then to the right of the screen, you're going to find 4 boxes that essentially give you a snapshot of what your practice profile looks like. It'll identify how many total number of residents were picked up through the methodology as having you as the most responsible physician, and then it'll give them their mean age. You'll get a breakdown of male to female ratios, and then what percentage have actually been new residents in the last quarter. Okay. And down at the bottom on the right, you'll see a pie chart, and the pie chart basically stratifies your resident population according to dementia without psychosis, any psychosis, and neither dementia nor psychosis. Again, to give you a sense of what your numbers are. And whether you feel that jives internally with what you think you have, if it should be fairly close, and if there's discrepancies, then it requires further thought and delving into to figure out why that might be. But at least it's a very quick way of assessing your practice profile. Next slide, please. So as you get further into the report, we're not going to go through this for every indicator, but we're just going to give you a quick overview of what it looks like. So this is for the overall rate. Again, you're going to find your own data in the green line in the graph compared to both your own LHIN and Ontario data. And below that, you're going to find a table, and in numbers format, you can compare percentages in the table for those who prefer looking at the numbers versus looking at the graph. And to the right of it, it helps you break it down further. If you happen to be working in more than one long-term care facility, we can break it down per facility, per home, so that you can have an assessment of whether or not one of your home populations is different than another, because we all know that there are some differences from home to home in terms of what the resident populations look like. And again, underneath you'll find a table format with your specific numbers. So that's essentially what the overall rate report page looks like. If we could have the next slide, please.
There was a question that we did have, and it was, what do you include in the psychotropic list? And Kara's here with me in the room. She can speak to that.
Yeah, I can tell you that we include all the typical and atypical antipsychotics in the list. Our drug list does differ from the CHI indicator on one medication. We do not include lithium in our list of antipsychotic medications. And in our technical appendix, which we have available online, it gives a full list of all the drugs that we're capturing as antipsychotics. So I think instead of my reading out every single one of them, it might be best if perhaps if you give us your email address and I can send that to you so you can see the list.
All right, thanks, Kara. So now I will move the slide forward now for you, Julie.
Thanks. So again, this is just a closer look at the overall rate. Again, simply describing your resident line versus that of your LHIN and the province with the accompanying data table underneath. Again, the data sources are stated below the table to help you understand where some of these numbers were obtained from. Okay. You might see in some of your tables an N/R, which means not reported or not available. Some people will find a not reported caption in one of their data tables, and those are usually to respect the confidentiality rules that we have to abide by. When numbers are too low, and too low being less than 5, they have to be suppressed and not reported. You might see that showing up in your report. So that usually means that the numbers are small and the suppression rules for it are such that we cannot display those numbers, despite advocating that you know who these people are and this is not necessarily confidential information. Nonetheless, rules stand and we've not been able to print those numbers for you. So that's what the NR usually states for, is that your numbers are low and they've been suppressed. Next slide, please. And again, same table, but broken down by long-term care home. Next slide. And again, looking at the overall rate by diagnosis for your own practice, you're able to determine from the table which of your residents have dementia without psychosis, any psychosis or neither psychosis nor dementia, who happen to be on antipsychotics. And again, you can compare yourself against your LHIN and the provincial averages. And that's where you might find suppression numbers as well, such as in this example where neither psychosis nor dementia on an antipsychotic, the numbers here are low and therefore they're being suppressed. And that's actually what we would like to see. Next slide, please. We've included in the report a variety of other scales that are being collected through the RIMDS tool that all the residents have on admission and then quarterly and then with subsequent changes in status. And, oh, sorry, I skipped ahead. This slide actually speaks to the CHI indicator. Again, in the data interpretation consideration section, it speaks to some of the differences between the HQO methodology and the CHI methodology, their inclusion of lithium, which is different than our methodology, as well as the fact that they don't have a 66 years of age cutoff. They look at all ages. So that's why sometimes the data will look a bit different, but it helps you again gain perspective on what your numbers are compared to your LIN and the provincial averages. Again, next slide. So here we go. This is what I was speaking to. There are a few other scales that we've included in the report to help contextualize why your numbers might be what they are, and again to help you compare yourself against your LIN and the rest of the province. Those include the aggressive behavior scale, a cognitive performance scale, the depression rating scale, and the pain scale, which will come, there you go, that's it there. And so these help you maybe determine some of the practice profiles that your residents have that may either explain why you might be finding higher rates of antipsychotics. If you could go back one slide, please. If you have a very aggressive, very severe aggressive behavior score that's quite high in your practice group, it would intuitively lead one to think that there might be a higher antipsychotic use in that long-term care home. And so it helps draw parallels and maybe explain some of the numbers that you're seeing in terms of your antipsychotic use. The cognitive performance scale is helpful as well in terms of whether you have a more or less demented than average population, either within your LIN or within the province. So we felt that those numbers could be useful to the clinicians in terms of better assessing the appropriateness of the use of the medications. Next slide, please. So same thing for the depression rating scale and the pain scales. These are scales that are being measured regardless. It's being collated through the MDS data set, and it is helpful to further assess your population. They tend to be validated against some of the tools that we may know a bit better, such as the Cohen-Mansfield or a geriatric depression scale or the Cornell scale for depression, but they're all very validated and useful to look at in terms of trying to justify the use of the medications or the withdrawal of medications. Next slide, please. Any questions at this point in time?
So Julie, we do have one here. I'm just reading. I'll read off the screen. It says, I only work in one nursing home, but my report is showing that I work in 2 homes.
Sorry, that would be a question to bring back to your billing agent. What we've noticed as we go through this process is the opposite. Typically, people who work in multiple homes seem to all be lumped into one home, and I think it has more to do with how the billing is entered and the institution code that's entered. Again, it would be something to discuss with your billing agent. If you do on-call at other homes, it's possible that she or he has changed the institution code and then just forgotten to bring it back to the one that you work in. So I think that's a cleaning up of your data submission. That might be the problem for that, but it would likely be something to discuss with your billing agent.
It seems to be all the questions we have right now, but please continue to enter them, and we'll be sure to ask your questions. And we'll have other times throughout to have some questions. So, thank you, Julie. Now I'm going to walk you through some of the change ideas in the change ideas section in your report. When you review your data, you might find an area that you may want to explore further as an area for potential improvement. And aligning with QI methodology, the first section of the change ideas, which will be near the end of your report after your indicators, helps to walk you through identifying what it is you'd like to focus on. So they focus on identifying what that area might be, setting your target, so whether you want to decrease or maintain, identifying a target, and then also identifying a time in which you want to reach that target. The second part of the change ideas section is walking you through some key questions. Sometimes it's hard to know, well, where do I start? I have the data, I understand the data. Now, if I find something that I may want to improve, where do I start? So these questions have been to help you walk you through this. To ask yourself these questions to see if there's an area of focus you'd like to to explore further. So for example, does your long-term care home have any improvement work underway? And what happens is that once you've identified a focus area, then you can review the change ideas that accompany each question. And these change ideas were created from the evidence as well as from subject matter experts, other physicians, QI specialists, and really compiling those into one spot. And this is not meant to be prescriptive. This is feedback that we got was from physicians was, where do I start? If there's some idea, giving you some ideas about where to start, and we've looked through and finding the best tools to help you in particular areas. Here's a snapshot of the 2 pages of those change ideas, walking you through the questions, and then below are the accompanying change ideas. So for example, number 1, you'll see below there's a column there with number 1 with the change ideas there. And then, so it walks you through, and then maybe some aren't applicable. And it's not saying that you have to do those, but it's like, okay, well, yeah, this applies to me, or maybe this doesn't apply to me. You can look at those change ideas to see if there's an area, something that you would want to change, or work with your team to look at. So, for example, with what Julie had mentioned before, with one of the physician's questions about, verifying the data, having that, making sure that the data is actually capturing all of your residents and such. And the last part, the last column here on, it says additional supports to help you. There's just a list of some other things that are out there that can help you in this area. And these change ideas will continue to be updated and revised based on emerging evidence and feedback that we do receive from the field. Other resources and supports. On the long-term care practice report portal, that's where you go to download your report. You'll notice here when there's a long-term care practice report tool, and this is where upcoming webinars will be information for those, information on particular tools, and as well as external events will be posted. And the recording of this session, of this webinar, as well as the slides, will be posted there for your reference. Additional supports also include Health Quality Ontario's Quality Rounds. They're a monthly session that focuses on different areas for quality improvement, and it's hosted around the province. And there will be an upcoming one in April on audit and feedback, and there'll be more information on HQO's website about that. There's also the Quality Compass, which is a repository of best practices, really focusing on how to do those things. There's a specific section on long-term care, and they relate to the quality improvement plan indicators. So for example, there is one on responsive behaviors. There's the IDEAS program, the Improving and Driving Excellence Across Sectors is a province-wide initiative to enhance quality improvement, leadership, and change management across all sectors. There's 2 programs. They are accredited. There's a 2-day introductory program and a 9-day advanced program. And they can be for yourself or staff that you work with. And the program builds on the international program pioneered by Intermountain Healthcare in the U.S. And now we have our own homegrown one here in the province. There's also the IHI Open School, which provides, HQO can provide unlimited access for 6 months to you or other colleagues you may have. It provides courses on quality improvement, person and family-centered care, leadership, and there's those courses as well as online resources. And if anyone is ever interested in that, they can always email HQO, and we'd be happy to set people up with that. So those are some tools and supports I've mentioned so far, but we really want to better support you in what you need. And we don't know what you need until we find out from you, because we want to make things that are going to be valuable for your use. So we have we have 2 pools, so we can help to identify what are those potential areas that you would want more information on. So I will open up the next poll, and it's asking, would you like additional support materials on any specific areas or topics? So one is that you don't need any more information, interpreting the indicators, acting on the data, hearing from your colleagues about what they're doing, about available resources. And those are only the options we have room for here. But if there's other things that you would want to learn more about, then I would ask you to add those into the question box. So if you can please take a moment and select what additional support materials you would find helpful. So it looks like the people who responded that most people wanted to hear from their own practices, from other physicians. All right, that is definitely something we've heard consistently in the last 2 webinars we've held, as well as discussions with other physicians. So that's very helpful, thank you. And the last poll is we've identified what it is, the area that you may want more information. The second part of that question is, well, how would you like to receive it? What is your preferred format for getting more information? So I will launch this final poll, and you can select all that apply. So it'll be webinars, printed materials, online learning modules, a discussion board, interactions with physicians in your own area, and if there are other ideas that are not listed there, please enter those in the question box. And it appears that 80% of those who voted would like printed materials, followed by interactions with physicians in your own areas and online learning modules. Thank you very much for providing your answers and answering the polls. So now we're going to open it up to hear more from your colleagues and to have more of a discussion, to hear about questions you may have. And Julie's also going to talk more about her experience as a physician, when she received her report. So I will stop the recording now, and then we'll open up for discussion.